All right, how are we doing? Awesome. So Thursday, ID test, right? So that's what you'll be studying while I'm lecturing. Got it. Tracking. All right. So if you look at the schedule, we're a little behind, but nothing crazy. I just don't like lecturing to, close eyes. So I kind of slowed down a little bit last week, but we'll play catch up. Okay. Any concerns with my course up to this point? Because we have one today and then one more lecture, and then tomorrow's the lab, right? And then one more lecture, and then I don't see you guys again until what day? And that's the test, right? So we'll coordinate a test review sometime next week. So if you have questions, concerns, comments of any kind, let me know. Okay? No questions? All right, let's get started. So we already talked about proximal biceps tendon rupture, correct? So distal bicep rupture is the opposite. But it's important to understand the physical exam findings and also how the patient may present, okay? So when we talk about distal bicep tendon ruptures, yes, they're less common, right? Only about 5%, but they're more significant as far as the implications when it comes to weakness, right? And we'll talk about that here in a second. We already talked about multiple times the insertion at the radial tuberosity, and there's a special test for that where you're trying to feel for that insertion and see if it's present, okay? What's that number right there at the bottom?
40.
All right. Okay, 40. So when we're talking about a distal bicep rupture, we're talking about a rupture at the insertion, correct? At the radial tuberosity. So therefore, you're going to have retraction of the muscle belly proximally and defect distally, right? Yes?
Good.
Okay, perfect. Severe pain followed by aching, ecchymosis, things of that nature. Okay, where do you think most of the ecchymosis is going to be, at least acutely? Is it going to be proximal or distal?
Distal.
Perfect. And then the reverse Popeye deformity. Okay, so we knew about the Popeye deformity. Now we have the reverse Popeye deformity. Good to go? All right, that little red arrow shows you which way the muscle belly is going. And this is going to be an important concept for you guys to pick up on. Okay, which one? Where is the defect? Palpable defect. Where is the injury pattern? All right, and therefore, which way does the muscle belly go when you do resisted flexion? We talked about that, right? Yes.
Yes, sir.
Okay, so physical exam-wise, there's that hook test. That picture there shows you the ecchymosis. The ecchymosis can be kind of tricky because, again, if it's long enough from injury, it may not present with a typical pattern. So I don't focus as much about the ecchymosis because, again, can you have ecchymosis and swelling distally, hours after the injury? Absolutely. All right, but again, resisted bicep worsens the deformity, and the muscle retracts which way? Proximal. Okay. Then we got the hook test. So the hook test is you're trying to hook the distal aspect of that tendon, right, in the AC, antecubital fossa, and more distally. Okay, so that's your hook test, right? So sometimes when you do the hook test, do you think that there is a chance that you could think you feel the tendon insertion, but you don't?
Yes.
Yes. Okay, so it can be kind of tricky. All right, so if we're thinking about a partial tear, a lot of times we get an MRI. So that's what's discussed here. Okay. Why would you get X-rays? Because you can actually see the avulsion, a little piece of bone fleck that comes off at the radial tuberosity. Can you guys pick up on that in the picture?
Yes.
Okay, good. I put the red arrow for you. All right, you gotta love the red arrow. All right, so MRI, ASAP. Do you think, based on, on the amount of weakness that people could potentially have, that we might want to get to these sooner?
Yes.
Right, so MRI as soon as possible. And that can help you discern an avulsion of the tendon versus a rupture at the musculotendinous junction, right? So avulsion, so it pulls directly off, or in the musculoskeletal tendon junction. Do I need to repeat that again? Nope. Okay. So adverse outcomes of disease, you do nothing. Okay. Loss of flexion strength can be upwards of 15%. Not as big of a deal, right? But loss of forearm supination power, that's upwards of 50%, and that's permanent. Okay. So again, we tend to offer surgery to most patients, and we'll talk about that. Right. So treatment-wise, non-operative is really reserved for partial tears, right? You got the MRI, you can see that. Older patients, okay? Older patients, sedentary lifestyles, so they're not high demand patients, okay? Is it their dominant versus non-dominant arm? And then also, if there's a delay in diagnosis. I had a soldier that came to see me in the South who was stationed at an army base there, and he presented a month later. Okay, so that's tough. That's tough. Okay, because remember we talked about how fast it starts to heal. So you're going to be chasing tendon. Which way does the tendon want to retract? Proximally. Good. So surgery within 2 weeks is optimal. Okay, it favors the best prognosis. Repair versus reconstruction, we talked about that. So repair is you take what God gave you and you fix it. And the reconstruction is you add to what was already there because it's either insufficient or not present. Everyone understand repair versus reconstruction? So a lot of times we try to do repairs, but especially in chronic cases or more significant tears, you may have to do a reconstruction. So you'll augment that with tissue. Do we take the tissue from the patient? It's the question you'll ask. We try not to, right? The answer is no. Okay, we don't. And there's a picture of that repair there. So it's just a couple of anchors. Do you think those anchors have to be super strong? Yeah, super strong, right? That's a strong attachment point. Okay, that's a great surgery, by the way. Do you have a bunch of nerves that run in that area? Yeah. So your job, if you go into orthopedic surgery as a PA, is to keep telling the surgeon, hey, dude, you're near. Okay, you're getting close. You're getting close. Okay, back off. Right? You're kind of like the checkpoint, if you will, because he's just focused on doing the Lord's business. Okay? So there's a picture there of how close things are together. Okay? And that's zoomed in, right? And everything's like well delayed, like it is an A&P lab. Does it look like that in real life? No. Right? You're going to track things down, and you're going to mark them and make sure you stay away from them. Which nerve? Perfect. Heterotropic ossification, I don't think you guys have talked about that, but have you? No? Okay, so HO, heterotropic ossification, is where you form bone outside of the skeletal system that's not normally there. So you form bone in soft tissue. Okay? Makes sense? And that's a high instance of that with distal bicep tendon ruptures. Re-rupture is always an concern, and re-rupture can be more significant as well if you don't do a good repair and switch over to a reconstruction. Okay? Any questions about distal bicep? It's kind of proximal bicep, but in reverse, correct? So in your mind, when you're studying, make sure you get the two clear. Okay? So moving on to UCL injuries, ulnar collateral ligament injuries. So it's the primary resistor to valgus stress at the elbow. By now, you guys know valgus teres, correct?
Yes.
Yes. Okay, good. So valgus, so going outwards, correct? Because the ligament is medial, correct? Okay. So sometimes if it's ulnar collateral ligament, can you sometimes see it written as medial collateral ligament of the elbow?
Yes.
Yes. Don't let that throw you off. Okay. Do you sometimes see it written as medial ulnar collateral ligament? Yes, just to be super redundant and confusing, correct? But to make sure you understand which one you're talking about, okay? Uncommon, right? But they can result in instability and or disability. So that's significant, okay? Instability, disability is seen with overhead throwing athletes, so baseball pitchers. Everybody heard of the Tommy John surgery? Okay, so something, if that's somebody's livelihood, you're going to want to address that. Okay, so a lot of times they'll feel a pop. Okay, so that's that sacroiliac pop, correct? So you can have ulnar nerve paresthesias in that distribution. All right, so it's important when you're getting your exam to understand which fingers are involved, correct? Which aspect of the form, etc. And swelling ecchymosis, though, usually minimal, if at all. I've seen UCL injuries where ecchymosis was really just around the medial epicondyle and not even anywhere else. Okay, so it can be a little tricky, so you can't just rely on that. Okay. So when we talk about that in physical exam, again, swelling ecchymosis can be very unimpressive. Okay, but you'll usually have a loss of terminal extension. Okay, so that's something when you're doing a range of motion, when you tell somebody to take their arms and extend them, you're comparing one side to the other, and you notice there's a loss of terminal extension. Does everybody understand the term terminal?
Yes.
It means end point, right? At the end, towards the end, okay? Towards the end of that arc. Tenderness at the UCL. You can have tenderness at the UCL with a bunch of different conditions, correct? Okay, so that may also not be specific. So since it involves the ulnar nerve, right, you can have that positive tenels. Yeah, but the biggest thing is when you do your valgus stress test, okay, especially when you do it going from extension to flexion, you can notice that then they have more significant pain. Okay, so that can tell you something. Good to go? Okay, did we talk about pain with other, like epicondylitis? The pain was in certain distributions, correct? When it comes to UCL injuries, they'll literally have pain, focal pain, usually at the insertion of the UCL. Okay? So, x-rays, always, right? MRI, though, with what? Arthrography, right? Arthrography, okay? So, and that's to diagnose the UCL pathology. There's a lot of things that live in a very small area, correct? Yes. You guys see that red arrow there? Can you see where the disruption there with the insertion?
Yes.
Yeah, you can see it, right? There's a clear gap. Okay. All right. I will not give you MRIs. So if you do nothing about it, what can happen? Chronic pain, instability, disability, correct? Chronic stiffness. They have a loss of terminal extension, correct? Stiffness is bad, correct? Good. Decreased range of motion. Well, I just said that. All right. So non-operative, I really reserve for people that are lower demand, if you will. But if you choose to do that, it's the usual. NSAIDs, RICE, activity modification. All right. So what kind of activities? Throwing motions. Okay. And there's that word, that service again that you can consult. Occupational therapy. Remember, they're the elbow, wrist, and hand people. Are you going to go sticking needles around the ulnar nerve? No, unless you hate the patient. Don't do it. Okay. But operative, 100% of competitive throwers. If throwing is your thing, we will offer you surgery. Okay. Surgical reconstruction. There's a Tommy John surgery. Famous baseball player. I don't know much about baseball, but that's all I know. Okay. I did go to a couple of Baltimore Orioles games. But basically, that is more of a significant surgery, correct? There's a lot going on there. Yeah, I won't get into that specifically. I would never ask you the specifics of surgery. Okay. Which nerve? Ulnar nerve. Okay. Is there a chance of infection? Sure. That's usually post-operatively, correct? That's why they put that there. In there. So, referral decisions, basically you have somebody you tried to treat, okay? Maybe you thought it was more of a low-grade injury, but they go on to not improve, and they fail non-operative treatment. You refer them to orthopedics, and we offer them the business. Okay, questions about UCL injuries? Nothing? Nursemaid's elbow. All right, I'll actually wait for a second. Any questions? No? Okay. That was fast. Nursemaid's elbow. Everybody's heard about this, right? All right. That's not handmaiden elbow. All right. Somebody told me a story last week. They got a call for a handmaiden elbow. I don't know what that is, but it's not nursemaid's elbow. Okay. Nursemaid's elbow, by definition, it's a subluxation. So can you liken the annular ligament as pictured there, similar to the sling that we talked about with the transverse humeral ligament? Yes, it provides restraint, correct? So if there's an injury, they can have increased motion there, okay? So it's important to understand that if the patient is predisposed to have laxity, so in certain medical conditions, Ehlers-Danlos syndrome, et cetera, You guys talked about Ehlers-Danlos syndrome in other classes? Not yet? Okay. So Ehlers-Danlos syndrome, English, is a condition that can cause joint laxity. Okay? But just understand that if they're predisposed to it, they can get this injury pattern. Make sense? You good? Okay. I'm not going to lecture on something I'm not going to test you on just yet. So, most common elbow injury in children less than what? 5. Okay? 5. So, when you're taking pants, make sure you're looking for the most common injury. Okay? Because when you talk about this, they're going to describe to you that they were at the playground, they went to grab their child's arm, they pulled on the arm, and all of a sudden the patient is been observed to not want to use the arm, and they're holding their arm clutched at their side. Okay, we'll talk about the position here in a second. So the history is important, correct? And guess what? They're less than 5 years old. The child will react and cry and not want to use the arm. Okay, so that's a telltale. The arm is held aside, elbow is flexed, and the forearm is pronated. Pronated, correct? So pronated means palm down, right? So that's the position you're going to find them in. And they're not going to want to use the arm. When you go to grab the arm, they will wince and pull back and cry and fuss. They're less than 5, right? So it can be a challenging exam. Everybody sees that mechanism there. There's a traction force, so there's that pull. Okay, and therefore there's a subluxation of what end of the radius? The head. Correct? Okay, radial head. Not radial statue, radial head. Okay. This is the position you may find the patient in. Random picture, but I think it serves a purpose. You walk in and everything seems to be chill, right? And then you go to grab the arm or ask the patient to reach out and they refuse. And when you go to grab the arm, they scream and spit. Some of them. Okay? True story. So they have tenderness over the radial head and resistance to attempted supination. So they don't want to go palm up, right? They're held palm down, they don't want to go palm up. Important things, anytime you have an upper extremity injury, you want to check your vascular status, right? So that's your baseline. All right, how do you deal with a 5-year-old? Can you feel me touching you? Right? Can you wiggle your fingers? Just very simple things, okay? AP lateral oblique of the elbow, okay? So AP lateral oblique of the elbow is usually going to be normal, unless there's a gross subluxation. All right, so everybody can see the arrow I added there, right? So that's supposed to be more posterior or inferior, depending on your orientation, correct? So that looks abnormal. So if there's any question about the radial head, like we discussed in MSK radiology, what study are you going to order? What view? Radial head, otherwise known as Greenspan view, okay? And so you look at it and you say, I don't know. You convince yourself you see something. Right? So what do you do if you're like, I'm just not sure? Get a comparison. Get the other side. Okay? Get the unaffected side. Good to go? So this is important to understand, all right, because this is something you can treat in your clinic and you don't need to send them to the emergency room. All right, so their arm is held in pronation, correct? So what you're going to do is you're going to put your thumb on the radial head and you're going to try to do what?
Supinate.
Yes, supination. All right, so you're going to try to go palm up. If that doesn't work, then you're going to flex them. Okay, you're going to flex at the elbow. So your thumb is applying pressure, gentle pressure, nothing crazy, right? And you're trying to go to full supination. Is the patient going to resist you?
Yes.
100%. Right? But the quicker you get it done, the quicker you can get out of that room. Okay? Because by then they're just not happy. Good to go? So there are other maneuvers we can do if that doesn't work, but this is what I want you guys to know. Thumb on which aspect? Right? So then you're going to go into, try to go into supination, and that's forced supination, meaning not forcefully, but you try to go to as far as you can go, not just a little bit. Right? You should feel that very satisfying pop. Has anybody reduced a radial head subluxation? Nurse example? Okay. not handmade elbow. That's something different. Okay? Any questions about that? Okay, so if you do that maneuver, you pop it back in, you send them home, correct? There's no referral needed. Right? But if you can't get it in, meaning you can't reduce it, or you suspect there's more going on based on either your exam or your radiographs or both, you refer them. Are we good with that? Okay. If you're in the ER, you're going to see these. Okay. You work a couple weeks in the ER, you'll see at least one. It's not what is it the most common injury?
Yes.
Yeah. So common things happen commonly. Remember that concept when you're studying the pants. Common things happen commonly. Okay? I hate this term, little leaguer's elbow. I'll go ahead and preface and tell you guys you need to read, in my opinion, the highlighted read. Because the book throws a lot of information with this topic. This general, it's not even a diagnosis, it's a category, in my opinion. Little leaguer's elbow. Because the thing about it is a 14-year-old in Little League, not always, right? So that's the thing, like you're talking about potentially older patients that kind of get lumped into this category. Okay, again, I call it a category, not a definition. So several pathologies that share a common etiology, okay? And the etiology is what? Throwing activities again, correct? Correct. So traction of apophysitis of the medial epicondyle, okay? So we know that where the physis is, right? So apophysitis, inflammation in and around the insertion there, okay? And that's traction, meaning there's a pulling. That's that repetitive throwing. What's the age for that one? I highlighted it for you. 8 to 12 years old, okay? But they can also have an avulsion injury. That's where they pull a piece of the bone, correct? It's just not traction, but they actually pull a piece of the bone off. And you can see that on radiographs and or MRI. That tends to be 12 to 14 years old. Why is that? Because the growth plates are closing, or closed, more closed, if you will. Make sense? Is this more common in males?
Yes.
Yes. So males tend to fuse that growth plate around 12 to 14 years old. That's why there's a range. Okay? Make sense? Okay. Ulnar collateral ligament injuries. Well, we just talked about that. That doesn't really change. Okay? I put there MCL at the elbow just to confuse somebody. Right? Because I keep telling you guys ulnar collateral ligament, but it's also the MCL, correct? Same thing. Capitellar OCD, osteochondritis dissecans. Okay? So that is occurs in patients that are greater than how many years old?
12.
So you see what I'm getting at? Like the 12 is kind of in there, and you're like, well, is it this, is it that? But the thing about OCD is that they have the loose body formation. That's what distinguishes it. So when you're reading scenarios on pants, you're looking for certain keywords. Good to go? Plantar disease, that's very specific. Okay, plantar disease has to be given to you in a way that describes it as an avascular lesion in the capitellum. Okay? In a child less than how many years old? 12, right? So there's that 12 again. So less than 12 and an OCD of the capitellum, right? So that's that avascular lesion in the capitellum. Then that means that you have plantar disease. Good to go? But that actually has a good prognosis. Okay? That one has a good prognosis compared to, let's say, a UCL injury, because a UCL injury is that where you actually have disruption, correct? Right? Okay, makes sense. This is just osteochondritis dissecans. It's avascular, so you rest the patient and they tend to improve. If you don't rest them, they tend to get worse in pain and can have more significant injuries that lead to instability and disability. Absolutely 100%. Good to go? Clinical symptoms, there you go. I wrote literally everything in the book in there. Okay? All right, copy and paste. But when it comes to this, these pictures don't do it justice. Okay? There's a lot of pictures on the internet you'll find to kind of try to break out those different diagnoses that I just gave you. Make sure you do if you have a chance in your spare time. Right? I would read the highlighted reading because it'll make it a little clearer to you guys. Okay? So pain with overhead throwing. Physical exam, tenor patient is the most common finding. Instability with UCL or with what? Severe lateral OCD or Penner disease. All right, if he goes on to progress, like I just described with OCD and Penner, then you can have things that mimic UCL injuries. Okay, do you have increased valgus motion with a UCL injury? Yes, we talked about that, right? So that's the thing that, you know, especially when you're looking at children, you want to make sure you get x-rays and or an MRI. Okay, because I can show you that avascularity. Good to go? Imaging, it will establish most diagnoses, okay, as far as radiographs. Again, if you see subtle changes and you're trying to convince yourself you see an injury, make sure you get comparison views. Good to go? An MRI is often necessary to see what? Which conditions are written on there?
OCD, Penner, UCL.
Okay, that's to differentiate, correct? So if you have somebody that's 11.964 of age, right? I'm joking. But you have somebody who's less than 12. If this question is excuse me, if there's a question as to the diagnosis, will you get an MRI?
Yes.
If you have somebody who's 12 years old and a month, and you have a question about diagnosis, will you get an MRI?
Yes.
So we very commonly get MRIs for little leaguers elbow. Okay? That's my teaching point for that. So how do you treat it? Take away the offending activity, correct? So 3 to 6 months rest from throwing. But if it's OCD, right, that's that avascularity, it's upwards of 12 months. So that's an important distinction. You got the MRI, you made the diagnosis. It's not just traction appendicitis, for example. It is actually avascularity. You have to shut them down. Good to go? Or OCD, excuse me. You have to shut them down. Okay, 12 months. That's a long time, right? Most kids that get this injury are highly active. So you tell a kid, and well, the dad actually, right? Because the dads are worse than the kids, especially competitively, that they can't do throwing sports. You think, what's the compliance rate?
Less than 50.
Well, he put a number on it, but I don't know if I can put a number on it, but it's not high, okay? So sometimes you have to do things to make them shut down. Braces, right? Splinting, things that restrict their motion, okay? Operative, occasionally, right? But if they have those loose bodies, do you have to go digging after those chiclets? Yes, okay? So everybody has heard me use the term chiclet before?
Yes.
Right, those little floaters, okay? So you see the no there? No throwing, okay? Conclusion, that's all the topics we discussed between last class and this class, okay? It's a lot of topics, right? All right? So hopefully, you know, in your spare time this weekend, you go through and you look at all those neuropathies, because you've got to get them straight in your head. Right? You can't just wait to see a question that says there is ulnar nerve distribution neuropathy. You need to get deeper. Make sense? Otherwise, you may suffer unnecessarily. I try not to make you guys suffer. Questions? Okay. We're going to roll right into it. Good with that?
Yep.
All right, we're going to talk about these topics. Animal bites, boutonniere deformity, carpal tunnel, defervins, dupuytren's, or dupuytren's. Okay. Fingertip infections, fingertip injuries, and amputations. There's going to be a lot of finger stuff coming out. Okay. But there's also some commonality, so we'll be able to press when it comes to the next lecture as well. Because we're going to talk about certain things over and over and over. Okay? All right, animal bites. Perfect timing. You guys just discussed rabies, right? Perfect timing. All right, so animal bites. So is there a high incidence of rabies in the United States?
Probably.
No. Then you talk about Hawaii, Guam, places like that. Still find cases, so those are technically still the U.S., correct? Okay, trick question. Dog bites, which one's most common? Dogs versus animals. Dogs versus cats, excuse me.
Dogs worldwide.
Okay, so that's what you want to think. You want to think to yourself, okay, dogs are more common, right? Dogs create tearing, okay? They grab on, they tear, right? Shake your head side to side, tear tissue, and they leave big open gaping wounds, okay? The infection risk, though, is 5 to 10%. So even though it's more common, the infection rate is lower. Now go over to the right side, okay? Cat bites are not as common, okay? But they're like hypodermic needles, okay? A cat bites, it's like an injection, 2 injections deep into the muscle, into the fascia, or the fascia, okay? All right, so when you get that, what? It gets into a deeper space, right? So what's the infection rate there? High, 30 to 50%. That means that when you see a cat bite, you need to think it's infected unless otherwise proven. Did I make my point yet?
Yes.
Okay, cat bites turn on a dime. Right? You look at a cat bite and say, yeah, we're good, we don't need antibiotics. They come back 6 hours later and you're like, oh my God, what happened? Right? Because the infection rate is 30 to 50%. Okay? So you guys already talked today about the treatment for it, so the rabies vaccination, plus or minus the rabies immune globulin treatment. Okay? So that's RIG, and that's, you see the abbreviation RIG, that's what that stands for. Okay? So they're typically polymicrobial though. I added this slide because I want to make sure you guys understand that when you're talking about causes of organisms, get it straight in your head that there can be a lot of bugs, right? We talk about bugs, and therefore it makes it polymicrobial. But what's commonly associated with dog and cat bites is Pasteurella multicida. Okay? Commonly associated, right? Although the most common organism is which one? Staphylococcus aureus, those great clusters, right? So I want you guys to understand that. When you see Pasteurella multicida, you're going to see that in cat and dog bites, but the most common organism is still going to be which one? Staph aureus, correct? And that's what that makes up that topic I just discussed, or that concept that it can be polymicrobial, correct? So the distinction here is that you got to treat for the Pasteurella multicida, okay? Because the treatment for Staph aureus that's not methicillin resistant is the same, correct? But when you choose the antibiotic, you got to make sure you cover that spectrum. Any questions about that concept? Okay, so read the question. Read the terminology when you're taking PANS tests. Make sure you understand what the question is asking you. Good to go? Everybody sees that top picture there? Is that a cat or a dog bite?
Dog.
Okay, that's that tearing, right? Dog grabbed on, shook head side to side, it tears. Big open gaping wounds. That puncture wound down at the bottom, what is that? Cat, right? So you see that progression there. Everybody wants to think that that progression from left to right is something that happens in days. That's just something that can happen in hours. So again, when you see a cat bite, you want to make sure that you understand that you need to treat it more aggressively because the infection rate is how high?
30-50.
30-50%. Okay, good to go? So a couple other topics we'll discuss with cat and dog bites. Make sure you ask them very simple questions. Is it your dog? Is it your cat? Do you know the vaccination status? Okay, if not, like you guys discussed quite recently in your lecture in infectious disease, are you going to treat?
Yeah.
100%. If there's a questionable history of vaccination, you're going to treat. Okay? But when they present, you can have very non-specific things like pain, swelling, and redness around the puncture. Again, if you go back to that picture I just showed you guys, that redness and swelling is not significant initially, but then takes off in the case of cat bites, okay? They can have loss of sensation and motion distally, okay? It may indicate a nerve or a tendon injury, and an unprovoked attack, your book says, may indicate rabies or a rabid animal. Sure. Just make sure, again, you ask about the vaccination status, okay? Everybody sees that picture on the bottom right? Do you see a big, torn, gaping wound there? No, that's a cat bite, okay? That's exactly what they look like 6 hours later, okay? So a physical exam, so if you're looking at your physical exam, you're doing a detailed exam, neurovascular status, and you get to a point where you're assessing, and you're looking, and you see that red streaking. What is that an indication of? lymphangitis, right, which is not the same thing as lymphadenopathy. If you don't know the difference between those two things, make sure you do. It's the ducts versus the drains. Okay, that's the way I think about it. Okay, lymphangitis is not the nodes. Good to go? Okay, but do you want to check the nodes as well? Yes, but just to make sure you understand your terminology. Purulent drainage presents 10 to 12 hours after injury. So by the time it comes back and it's purulent, right? Not that other word. Okay, it's purulent. It can be more significant in clinical presentation. Correct? So don't let that fool you. Calf bites are infected unless otherwise proven. Okay? You need to gauge the depth and extent of the injury. Okay? So what levels did it get to? Was it superficial? Was it above the fascia? Right, below the fascia? Test sensation and function. Make sure you test all sensation and function. Okay, compared to the contralateral side. Okay, you see that picture at the bottom right there? They seem to be isolating certain fingers there, correct? So they're isolating which finger? The middle finger, right? Make sure you isolate and test each finger individually. There you go. Okay. Somebody wanted to say long finger. We'll get to that point. Okay. Imaging. All right. Foreign bodies. Okay. Breaks in the soft tissue. They indicate gas in the soft tissues. Does everybody see that blown up picture of the tooth?
Yes.
That's a real case, right? Provider saw the patient, did everything they needed to do, didn't get x-rays though, and the patient seemed to be doing okay, and they came back a few weeks later, and all of a sudden it was a fulminant infection, raging infection, just angry. Okay, so is that tooth something you want to get out of there?
Yes.
Yeah, so you get the x-ray and you're like, I see a tooth. You're going to call somebody, okay? Depending on where it is, it's general surgery versus orthopedics, but we won't get into that. That's the turf war, okay? Lab studies, we talked about this like a million times, right? CBC, ESR, and CRP, correct? If for no other reason, you're going to get those labs to monitor for progression, correct? So it's a baseline. You're going to check to see if your treatment's effective and or the patient is worsening, okay? Make sense? Wound swab, can these be polymicrobial? Yes. So if it's a wound swab with a superficial wound, you can expect to have it grow out a bunch of stuff. Okay? So the real way to get a good culture is to do it intraoperatively, and you actually take a piece of the tissue and a deeper culture, right? But if there's a question about it, you'll get cultures. They're called wound swabs, correct? But just understand it may be contaminated by skin flora. So when you get that report back, you're like, I don't know what to do with this information. Well, you're going to do presumptive treatment with an antibiotic that favors the coverage of multiple spectrums. Correct? The answer is yes. So adverse outcomes disease, they're numerous. Okay, but are most of these things infectious in nature?
Yes.
Absolutely. Will rabies kill you?
Yes.
Not you, the patient, right? So yes. Make sure that if there's a question about rabies, you can ask. What's the other thing you want to ask them their status of?
Vaccines?
Vaccines as far as tetanus, correct? Okay, so that's the first two questions. If you call me on the phone, I'm going to ask you, was it their dog, somebody else's dog, and what's the vaccination status? And do you have the dog? Okay? So treatment, we discussed that earlier as far as the vaccinations, but you just want to make sure you understand that you need to decide whether or not the wound is superficial or deep. Okay, depending on your comfort level or your capabilities, if it's a deeper wound, are you going to treat that in clinic? Yeah, you're going to send that, okay? Or you're going to consult and refer, okay? So the big thing to understand this is that if it's a superficial wound, with no nerve or tendon injury, then maybe you can do more conservative, okay? And there's no active infection. So what are you going to do? Copious irrigation and debridement. Everybody understands what irrigation is, right? The solution to pollution is dilution. That's the saying that you'll hear in ER at some point. Okay, so you just put a lot of fluid in there to try to wash it out, essentially. Okay, so what is debridement? Debridement is where you go in there and you actually start taking away tissue margins, areas of poor tissue viability, so it looks like it's not going to survive, so therefore you take it off, 'cause it's gonna fall off anyways. And also you're debriding any kind of foreign bodies or other gunk that's in there, okay? So are dog mouths dirty sometimes? Yes, polymicrobial, correct? So your book says 1 liter of saline or antibiotic fluid. I will tell you that 1 liter is the minimum, okay? There's a famous case of litigation where people say, you're gonna document you did copious irrigation. That actually is a legal term. Copious irrigation means you did 8 liters minimum. Okay, so if you're documenting copious, you better have done more than 1 liter. But your book says 1 liter, so I'll stick to that. Okay, but you're gonna flood it with as much fluid as you need to make sure you have clear margins and that you don't have any gunk in there still, correct? Yes. And which is the gold standard?
Okay.
Augmentin, correct? So augmentin, wow, we don't get into the pharmacology, I know you guys love that, but that's that NAB-NAD complex and all that stuff, correct? So that's something that you're going to treat all dog and cat bites, correct?
Yes.
Notice, excuse me, that I said dog and cat bites. We will talk about human bites too. Differentiate that, okay? Do not suture the wounds closed tightly, okay? I get this very commonly at all levels of practice. People want to do this beautiful plastic, cosmetic closure, plastics, right? Plastic surgery, right? What are you doing if there's still stuff in there that could potentially cause a reservoir infection? You're just closing it off, correct? You're not allowing it to drain, right? You're creating a greater opportunity for infection to set in. So loose approximation is best. Good to go? Okay, loose approximation. Don't close it tightly. If you think you need 6 sutures to close that wound, you're going to need 3 to actually close it. It's going to be loose. It's not going to look pretty. I have pictures on my phone if you want to see some stuff I did recently before I PCS. Okay? It doesn't look pretty. It's not cosmetic. But again, you want to allow the wound to drain. Did I kill that horse sufficiently enough? Okay, good. Active infection, well, that's easy. You did your exam. There's active infection, right? It's significant. That patient is likely going to be admitted for IV antibiotics. Okay? Once they show signs of improvement, I would say in 48 hours, I'll use that number, but we check them the day of, the day after, and then the following day. So 48 hours is what your book says. I'll stick to that. But 48 hours, then you can discharge the patient on oral antibiotics, correct? Now, incidentally, are the antibiotics you're going to use inpatient the same as the antibiotics you use outpatient? Not necessarily, okay? But I will allow you guys to have the fun and pleasure of pharmacology to discuss the antibiotics. Okay? You guys already had that, so let's review that, okay? Operative indications, anything that's infectious, correct? So do you think I get a lot of phone calls about cat and dog bites? Dog bites, I'm like, is everything working? Is everything okay? Is there any fevers, chills, nausea, vomiting, diarrhea? Anything else going on? No, okay, good to go. Send it to my clinic tomorrow. Cat bite? Ooh, you said cat? Yeah, I need to see that. Okay? Good to go? All right. So even after you close it, can you have complications? Yes, but the complications tend to be more so, again, in the watertight closures. That picture on the bottom right there, that's a wound dehiscence. That's where somebody closed it nice and pretty, and then it popped, right? You guys heard the term pus under pressure? Okay, if you haven't, you will in your ER rotation, because anytime there's pus, purulent drainage, they're going to yell, PA student, right? And you're going to go there to witness the nastiness, okay? That was my experience, okay? But so if it pops because of the pressure or because you just did a poor job closing it, that's wound dehiscence. Good to go? And then allergic reaction to antibiotics. If the patient has an allergic reaction to antibiotics, then you don't use those. What's the common stuff we talk about? Penicillins and sulfates, correct? Yes. So make sure you get a good history, okay? Incidentally, when you guys are doing that washout, are you going to just go for it, or are you going to numb the patient up?
No.
You're going to numb them up, okay? And you'll talk about that in the EMED and some other procedural courses, but you want to make sure you get a good allergy history before you touch the patient, not after, okay? Good to go? Because you'll capture things like, again, allergies to anesthetics, or I should say sensitivity to anesthetics, or allergies to antibiotics. Okay, so the red flags for this is going to obviously be extensive tendon injuries, okay, nerve injuries. So you're doing isolated finger testing and one finger doesn't fire. You gonna refer to that?
Yes.
100%. Joint capsule violation. I cannot stress this enough. You need to make sure that there's little, I would say no concern for joint capsule violation. Okay, because then if it violates the capsule, right, and that bacteria gets down in there, what's that called? Septic arthritis. We talked about that, right? So now you got a whole other condition. Is septic arthritis a surgical concern?
Yes.
Absolutely. And if there's an underlying fracture, okay? And we'll add here to that foreign body. If you see the dog's tooth and you can match it to the gum line, you need to call me. Okay? All right? Good to go? We are going to break before someone breaks their face on their desk. There's a 4 minutes now. So boutonniere deformity. Boutonniere deformity. Okay? So when we talk about boutonniere deformity, it's important to understand that that is an extensor tendon injury, technically. Well, more specifically, it's the central slip of what? The extensor tendon, right? It's in yellow, it's underlined. It's important to understand that that's where the injury pattern is. Is that on the dorsal or the volar aspect of the finger? Dorsal. Okay, so that will be important to understand because that will tell you why you get the deformity you see with this. Okay? So the PIP, the proximal interphalangeal joint, right? It does what? It flexes from the pull of the flexor tendons. Okay? So just because one aspect is out, which is what? The central slip, doesn't mean other structures are not intact, correct? So then you're going to continue causing what's called deforming forces. In orthopedics, if you come to orthopedics, you'll hear that term all the time. Deforming forces. What are the things that are pulling to cause a certain type of deformity? Okay? So the proximal phalanx head buttonholes through the defect. Have you guys heard the term buttonhole before? Everybody knows what a button is, right? On your shirt. So when you have a buttonhole and the button goes through it, that's a buttonhole. Okay? So basically what happens is that you have that flexion because there is the pull of the flexor tendon itself. Okay, so that's where you have the buttonhole. Did everybody see the buttonhole in here? See how the button is the aspect there of the bone? Okay? It goes up and through. You see that? Right? So that's the buttonhole. It's as if though you're putting the button into the shirt hole. Make sense? Okay? You're welcome. So the lateral bands displace palmar. Okay? So again, palmar is another word for volar, correct? And the DIP joint extends or hyperextends. So the PIP does what? And the DIP does what?
Extends.
Or hyperextends, correct? So that's going to be important to remember when we start talking about other finger deformities. Okay? So when you see it, it looks just like that. Okay? But you're going to have a history of trauma. There's some precipitating event or trauma, right? Injury or insult. And then the finger will lie in a partially flexed position at the PIP and extended or hyperextended to the DIP. Okay? Now it's important to understand that they won't always present like this right away after certain injuries. Right? There's a central slip disruption, okay, that causes that buttonholing we just discussed. But the injury can sometimes set in a week to how many weeks? 7 times 3 is 21. Here is a 2. Yep, my math is right. Okay. So 1 to 3 weeks. Okay. So or 7 to 21 days, however you want to remember it. Okay. So there are certain injury patterns that we see that we're like, oh, we need to keep an eye on this to see if he develops a boutonniere deformity. Okay. So you want to check range of motion at the MCPs, the PIPs, and the DIPs, right? The thumb being the exception. Does the thumb have a DIP and a PIP? No, it just has an IP, correct? Okay, good. Don't let that fool you. Don't get pimped. on that, okay? So the deformity, as a rule, will worsen with flexion, okay? And patients who lack 15 to 20 degrees of extension at the PIP has a central slip rupture unless otherwise proven. Make sense? Okay, so you think you'll get an MRI?
Yes.
Okay, so you read the scenario, it says they have a 16.78 degree, that's a joke, but say that it's 15 to 20 degrees, then the answer is what? It's a central slip disruption, and therefore the patient's at risk for a boot and ear deformity. Good to go? Is it in yellow?
Yes.
Good. So boot and ear imaging, I found this. I like this. I like this picture. It just so happened it used red and gold, so I liked it even more. Okay, but that's what you're going to see on imaging. You're going to see that flexion at the PIP, and you're going to see that extension or hyperextension at the DIP. Well, you might ask yourself, if I can see it, why do I need an X-ray? Well, you got to rule out an avulsion fracture. Okay, I could spend 3 hours talking about just this one injury and still not get to it. Hand surgery is its own subspecialty for a reason. But you will get an X-ray to rule out an avulsion fracture, because if an avulsion fracture is what's causing this, it may not be a true isolated central slip injury. It may have other factors involved. Are we good with that? Okay. So you're going to rule out avulsion injuries. Okay. Adverse outcomes disease, you do nothing about it. Do you think that finger is going to heal in that position? It's going to get stiff?
Yeah.
Yes, that's troublesome for function, right? So I tried to show you that in that picture there as well. That's how they'll heal. Okay? And that's a contracture, right? We define what a contracture is. Okay? So non-operative treatment. So non-operative treatment is what? NSAIDs, rice, activity modification. There's that word again, occupational therapy. And then, but for how long? So you got to keep that PIP, okay, in a certain position for how many weeks?
6.
And the DIP is free. A rule in hand orthopedics, or orthopedic surgery, hand subspecialty, is that you do not immobilize joints that don't need to be immobilized. This is an example of that. Okay? How many weeks for elderly patients?
3.
Okay? So elderly patients are like, that sucks. But you want to immobilize it for 3 weeks, and then probably it's still not offering surgery. Right? So, but I don't want to get into that. So operative, so you did all the non-operative treatment, they fail. Okay? Or they have a persistent deformity. If somebody presents to me at a month after this deformity is set in, do you think the treatment is better or worse than if they present to me a week after this this condition sets in?
Worse.
Worse. Okay. So again, they can have persistent deformity. Those splints that you see there, okay, the one on the bottom left, okay, that's an 8 stack or a figure 8 splint. And the one on your right is a more fancier one. Okay. So basically, what that's doing is it's allowing for the PIP to remain an extension. Okay, but it's freely moving at the DIP. Good to go? Okay. You'll find those in your clinics out there. So adverse outcomes of disease, again, you're going to be unable to achieve full extension and residual PIP flexion deformity. Referral decisions, if you decide you're going to try that 6 weeks of splinting and the patient does not get better, you're going to refer. Okay? Or if the patient comes back and then you see a residual deformity, you're going to refer. Questions about boot and ear deformity. I think it's super important for you guys just to start keying on when I emphasize things with these deformities, because they'll throw you off. Okay? Because you got to be able to look at a picture potentially. Okay? And you decide what deformity it is. You look at it and you say, well, what's the PIP doing? It's spliced. What's the DIP doing? It's extended or hyperextended. Good to go. What if you have extension at the PIP and then flexion at the DIP? Do you think that might be a different injury?
Yes.
The answer is yes. Okay. Any questions about that other than what I just said? Okay. Carpal tunnel syndrome. So who in here has carpal tunnel syndrome? Huh?
Okay.
According to statistics, at least one person here does. So I'll go ahead and raise my hand. Okay? just I don't want the world to be alone there. Okay? Well, which nerve is involved?
Median.
Perfect. Is it young females or old females?
Middle age.
Perfect. Do pregnant women get this a lot?
Yeah.
Yes. And their OBGYN sends them to me, and I'm like, what do you want me to do? Now you can't give a kid Tylenol because you're going to get autism. You know, so what are my options, right? So median nerve compression, that's an upper extremity compression neuropathy. We beat that horse to death. Okay. All right. So it's a reduction in that carpal tunnel. Everybody knows what the carpal tunnel is, right? Is there a band of tissue that goes across there that you can release if it's causing compression?
Yes.
The answer is yes. That's called a carpal tunnel release. You've heard of that. So which condition did we talk about that gets it a lot? RA, rheumatoid arthritis. Is rheumatoid arthritis involved the wrist?
Yes.
Does it involve the DIP joints? Oh God, please help me. Does it involve DIP joints? No. All right, okay. All right, because if you don't read the question, you might answer that, right? Wrong? Okay. Thyroid dysfunction. Does the thyroid regulate hormonal balance in the body?
Yes.
Okay. My back just popped when I did that, so I had to hold that position for a second. So, clinical symptoms. So how do you think they're going to present then? We already kind of talked about this, that thenar atrophy, right, or hypothenar atrophy can present in long-standing cases. If somebody presents with that atrophy that is demonstrated in that picture there, do you think you're going to refer them 100% of the time?
Yes.
Yes, because that's long-standing injury, right? That distribution, I highlighted there again, thumb, index, and long finger. Okay? If they have early disease, it's intermittent paresthesias. If they have long-standing disease, it can be more persistent paresthesias. Good to go? Okay? What's the thing that they get it from? Repetitive activities, and also patients that do a lot of typing. Their wrist is held in this position, right? Extended position. Okay? So history is important. Read the scenario. Good to go? Okay? What's the thing I told you guys about hand injuries? Ask the patient, do you have trouble turning doorknobs or opening pickle jars? If they don't eat pickles, make something up. Okay? But I'm just telling you, you're going to ask them if they're having trouble with fine manipulation or with turning doorknobs. Okay? Everybody sees the hypothenar atrophy there?
Yes.
Okay? I try to give you guys a better picture. But they have some questions in there. What does that look like? That's what it looks like. Okay? So you're going to literally tell them palms out like this, and you're going to look at it and look for muscle bulk, and tone. You guys have heard those terms before. Bulk is pretty self-explanatory. Tone is it feel like it's supple? You know, when you push on it, it pushes back. Things like that. Make sense? If I say something that doesn't make sense, tell me. Okay. Thumb opposition against resistance. Ooh, here we go. Talked to you guys about this with CMC grind test, CMC arthritis, things like that, right? What is okay sign? What are you testing with that? Nerves, right? So if you tell somebody to do this, but while they're doing this, you say, okay, now I'm going to put a piece of paper in there, okay? And then all of a sudden they go thumb, pulp, right? Thumb pulp, everybody knows what thumb pulp is, okay? And then index pulp, meet, and they're unable to keep the okay sign. Does that indicate weakness?
Yeah.
I thought you guys read that before, right? So, yes, the answer is yes. I think that's what she said. Okay, so that's what that gets into, okay? Compression test, most useful, okay? What is the compression test called? It's also called a Durkin's test. Have you guys heard that term yet? Durkin's? Yeah, you may hear that, especially with fancy hand surgeons. They love to use fancy terms like that because they're like, oh, this person doesn't know what a Durkin's test is. But basically, you're just compressing the carpal tunnel. Be aware, and we'll discuss this in lab tomorrow, that the carpal tunnel is more distal than you think. A lot of people compress the wrist, but not the carpal tunnel. Okay? Valence test, you guys know that one, right? This one, balance test. Okay. All right. So now this test, it's like the elbow one, but guess what you're tapping on? The carpal tunnel, right? The median nerve. Yes, that's correct. Okay. 2-point discrimination. So what's 2-point discrimination? And for easy purposes, you can take a paper clip, unroll it, okay, and go tip to tip, okay, side by side, and 5 millimeters is normal. Okay, are there fancy tools out there that do 5 millimeters, 6 millimeters, 8 millimeters, etc.? Yes, but 5 millimeters is normal. I think you should know that. Okay, did you guys learn that in neurology?
Not yet.
Not yet, but you're saying there's a chance.
Maybe.
Diagnostics wise, well, this is compression, right? So do you think if you get x-rays, it's not going to show anything? Yeah, a lot of times it does not show anything, okay? But you want to get x-rays, just to make sure you're ruling out any other processes that could be occurring, okay? But one of the most useful things, as far as confirming it though, is EMG nerve conduction studies. On the part it says, in your book it says, but rarely required for diagnosis. In surgery, we'll often get EMG NCS, because as you guys know, we're going to learn in surgery next semester, there's something called a surgical indication. That means it's your way as a surgeon of telling the world that I did this surgery because it was indicated. I got an EMG nerve conduction study, and it showed there was delays. There was latencies. Good to go? Everybody understand the difference between confirmatory and absolutely 100% required?
Yes.
Okay. Good to go. Good. Hand weakness, permanent loss of sensation, that makes sense. Okay. Carpal tunnel syndrome, excuse me. Non-operative treatment, NSAIDs, RICE, activity modification, and then also occupational therapy. Splinting in neutral, okay? Now this is a cockback splint, okay? Or some form of splint that holds the wrist in a neutral position. Okay, proper ergonomics. Remember I talked to you guys about keyboards? So if somebody sits with their wrist hyper extended like this, or extended, excuse me, like this, then you want to put them in better posture and position, correct? And that's something that occupational therapy can counsel them on too. Steroid injections, if above fail, okay? It's not uncommon for us to do steroid injections, okay? As long as you do them in the right place, it can actually not only be diagnostic, but also therapeutic, right? We talked about this before. So it can be another surgical indication. I did the injection 2 months ago. They got 100% relief, but now it's back. Make sense? Okay? For surgery, non-operative treatment failure occurs. There's a sensory loss or weakness of what? The theater muscles. All right, so you have that wasting. And the surgery for that is a carpal tunnel release. Okay? If you're fancy, you can do them arthroscopically, but usually we'll do them open. Hand surgeons will do arthroscopy. But you basically go in there, you release that band of tissue, and hopefully decrease the amount of compression that's occurring. Okay? Complications, well, with any surgery you guys are picking up, infection is a concern, right? But the thing about it is when we counsel patients on this before surgery, is that you may not get 100% relief of your symptoms. You may still have some degree. So is pain-free something I ever use in my vernacular in orthopedics? No. Okay, they're going to do surgery. You may form scar tissue. You may pull on the nerve. Bless you. My bad. Right? Just twang on that guitar string a little bit, and then they have persistent symptoms. Don't tell the patient they're going to be pain-free after orthopedics. I will find you. Okay? So where's that number?
3 months.
3 months. Okay, good. Yes, we talked about that. Persistent numbness weakness. Okay, decorvin, tenosynovitis. Sometimes you'll see that as DQ tenosynovitis. Okay. If I swear to God, if you use this term in a spelling bee, nobody would win, because people spell decorvins wrong all the time. But this is how you actually spell it. Okay. Decorvin, tenosynovitis. Remember we talked about this a little bit. First dorsal compartment. Okay. What are those structures, guys? APL and EPB, correct? Abductor pollicis longus and extensor pollicis brevis. Okay, so that's the two structures that are found in that first dorsal compartment. Okay? Does anybody know how many compartments are in the wrist? Homework. Okay, so women get this. Postpartum tends to be very common. Okay. Okay. Postpartum, they can do a little bit more after that, but if they're breastfeeding, maybe not. Right? So altered hormonal states and repetitive ulnar deviation. That ulnar deviation will come up again. But everybody sees that thinner snuff box. We don't really use that term, okay? But that's a way to distinguish between snuff box, tenderness of palpation, like we talked about before, and or first dorsal compartment tenderness of palpation, okay? A lot of times, and we talked about this, do patients have positive snuff box tenderness of palpation with this condition? Yes, it's in the differential. Okay. Radial styloid. Which side? Radial. So that's how they're going to present. Your scenario will paint the picture of a radial-sided wrist pain. Pain with moving thumb or making a fist. Creaking as the tendon moves. I actually had a patient that had a very profound case of this. It was impressive. Okay, it was almost like nails on a chalkboard. It was pretty bad. But you see that red splotch there? That's your pain distribution. Okay, makes sense? Okay. So this is decurvent sinusitis. Okay, what's the special test for this? Finkelstein. Okay, I love that word. Finkelstein test. Okay, so you have the patient put their elbow to their side, 90 degrees of elbow flexion. You tell the patient to open their hand, put their thumb into the palm of their hand, grasp their thumb, close it. Then you have them ulnarly deviate. Okay? Ulnarly deviate. And that causes pain along that first dorsal compartment. Everybody understands that? So it is not wrist flexion. It is ulnar deviation. Make sense? Because what happens is if you don't put the patient in this position and you have them out in space, are they going to want to flex? Yes. You only want, the answer is yes. You only want them to do ulnar deviation to put maximal tension on that first dorsal compartment. Okay? Do you think you're stretching the APL and EPB and causing compression? Yes. So that reproduces their pain because you did it properly, and they're not flexing at the wrist. Okay? Then that is decurvent sinusitis. You good with that? So it is ulnar deviation. Don't worry, somebody will get it wrong. Okay? So imaging-wise, why do you want to get imaging? Because if it's long-standing especially, they can have some bony reactive changes. Remember that tendon I was talking about that was causing that creaking? Just imagine that, right? The patient said they could actually hear it sometimes. So do you think that can cause bony reactive changes? The answer is yes. Okay? So you want to rule out deformed radial styloid. Sometimes people have certain congenital findings that can predispose them to having decurvent sinusitis. They can have calcifications and OA, right? You guys are sick as heck about OA, right? But there it is. Okay, so if they have a history of previous trauma, not recent trauma, previous trauma, they could have osteoarthritic changes. You good with that? You like the nice blown up picture I found you? 3 arrows instead of 1. Okay. Obviously, you know, if they have that creaking and that friction there with the tendon, a tendon rupture is possible. I've never seen it. Okay? You may have seen me, but I've never seen it. Good to go? Okay. So thumb, splint. What kind of splint are you going to choose? Perfect. And can you do a steroid injection? Yes. I will tell you that we tend to not want to do steroid injections early on, because what happens if your patient comes in and they have pain and you say, well, I can give you an injection, they get better. Right? The pain goes away 100%. Do you think they ever actually do the rehab for it?
No.
No. Okay? So that's why I kind of like slow roll it a little bit, right? But if somebody comes in, let me flip the script. If somebody comes in and they have so much pain that you know if you send them to occupational therapy, they won't be able to do a thing there. Do you think an injection in that case might be the best thing to do?
Yes.
Yes. You don't want them to go stare into the OT therapist's eyes, right, for like an hour, and they say, I can't do that, it hurts too much. I can't do that, it hurts too much. I can't do that, it hurts too much. That's a waste of time, okay? But I'm just trying to get you guys thinking a little bit, okay? Good to go? Non-operative treatment failure is a surgical indication, all right? So we don't just do these. Is the risk of infection 0? No. And anytime you have anesthesia, the risk of death is also not 0, correct? So it has to be indicated. And so what are you going to do? So it's a compartment. We can release it. Make sense? You guys like that little picture I found for you? You can see the EPB and APL and that interval in between it. And then you can see where the surgeon wants to make the incision. Okay, so you can get in there and open up that compartment and make sure you get the whole thing released. Good to go? You can do that arthroscopically. Yes, the question was, can you do that arthroscopically? You can. The risk with arthroscopic releases, though, in this case, is that you may get an incomplete release. Okay? But can you bill for the same surgery twice?
Yes.
That's a joke. Sorry. Okay. So radial nerve is the one in, yes, sir. That's a good question. I haven't met one yet that does. Now, the question he asked is, can OT do steroid injections? And the answer is, you heard my answer. I haven't met one that does them yet, but I don't know. I don't know if that's in their scope. Okay? So that's good. I'll look that up. Okay? I like homework. You guys hate it, I love it. Okay, radiosensory nerve injury with either injection or surgery. Okay, you guys will learn about these injections in phase 2. Do them. Okay, if you can, do as many as you can. That's the only way you're going to get comfortable with these. Okay. Failure of non-surgical treatment after how many months? Okay, there's the weakness, numbness, and finger and muscle atrophy again. We go with carpal tunnel syndrome. I will caution you when you look at CTS. Right? In the elbow, we talk about cubital tunnel syndrome, correct?
Yes.
So a lot of times you want to make sure when you're writing things, people understand what the heck you're talking about. If you just write CTS, that could either be cubital tunnel or carpal tunnel, correct?
Yes.
Okay. Good. Dupuytren's contraction or Dupuytren's, depending on how you pronounce it. It's in the elbow, palmar fascia. That's at the palm. Okay. That is not at that A1 pulley that I referenced before. The A1 pulley is a whole other condition called what? Trigger finger. We'll get into that. This is in the palmar fascia, or fascia. Okay? Men older than 50, Northern European descent. I don't know if I've ever asked that question. That question. Are you from Northern Europe? Right? But there you go. There's your distribution fact of the day. That's why it's not in yellow, guys. So diabetes is on that list, isn't it?
Yes.
Okay. So do you think diabetics have a higher incidence of Dupuytren's?
Absolutely.
Yes. Thank you for answering so I can move on. So ring finger is the most common. Okay. I have one. If you guys want to do show and tell afterwards, I'll show you, but I'll never tell. Okay. So, but ring finger is exactly where I have it. Okay. Is there any utility of learning what it's followed by? No. Ring finger is one. Okay. Ring finger tends to be the one you're going to see. Okay. They can have pain with pressure. Okay. Now remember, right? I told you guys the distal palmar crease, right? If you take your hand and you put it like this, right? Everybody sees what I'm doing? That crease, when you look at your palm, that's the distal palmar crease. If it's at or proximal to it, especially proximal to it, right? So closer to your elbow, that's Dupuytren's. If it's distal to it and there's triggering, that is trigger finger. Make sense? That's how you read a scenario and try to figure out what the heck they're asking you, okay? Difficulty with extension and grasping. And then do you think if their finger's in that position there, they're going to have a hard time putting that hand in glove? Yes. Okay. Have I ever asked a patient, do you have trouble putting your hand in the glove? No, but your book tends to highlights it for some reason, so there you go. But is sensation normal or abnormal? Normal?
Normal.
Okay, I just want to make sure. Okay, he's up there making stuff up. All right, so normal, correct? Okay, good. So they can feel a callus or some kind of a nodule there. Okay, but once it's long-standing, they get that look of what's called a cord, right? It looks like a thickened cord. Okay, so that's dupuytren's. Okay, and if it's fixed position and the finger is in that position there, that's called a contracture, correct? So if the scenario gives you a finger contracture, dupuytren's should be at the top of the list. Okay? Good to go?
Yes.
Contracture, limited function, right? So, NSAIDs, RICE, anterior modification, occupational therapy. Do you think sometimes they can do custom splints that progressively put their hand in more and more extension at the MCP?
Yes.
Okay, so that is what they do. Okay, so it's that nice, slow progression, but not curative. So what that means is you get them to a better functional state. Now they can put their hand on the glove, for example. Okay. And then over time, do you think they can flex down again, get a contracture, and cause those cords? Yes. Collagenase injection into the lumbar cord? I don't know. The studies seem to show that that helps. Okay, that's something you're only probably going to get from a hand surgery clinic. Okay, I won't harp on that too much. They offered it to me before, but I don't like people sticking needles into my hand. I don't know about you guys, right? And I don't know. Can it return even after the injections?
Yes.
Yes. So I'm like, I'm good. I get tortured enough at home. Okay. So operative, those are the operative indications there. 30, 10. What's the next set? I'm sorry, 30 MCP, and the next set is 10 PIP. 30 MCP, 10 PIP. Okay? And what do? Contracture release. You literally take it and you release it. Okay? So sometimes we get a little aggressive, and we have to do a little bit of a repair. Yes. But nobody does. So.
Sorry,
Yes, sir.
How fast is the onset? Like,
It's over time. So I've had mine probably for about 8 years.
8 years? Okay.
Yeah, and I don't have any, I mean, some would argue, right? There's nothing wrong with it. That's what I say. But I don't have any loss of extension, right? But it could all of a sudden I could wake up tomorrow and I'm like, wait, I lost like 1 degree. Right? So when we talk about those numbers, right? Those numbers are 10 degrees at the PIP. That's not very significant, right? 10 degrees is pretty insignificant. Makes sense? But it can cause a very profound amount of disability. Okay? Did I answer your question, sir?
Yes.
Yes. Okay. So I think his question was like, how long does it take to come on? If they're diabetics, it tends to be more advanced. Okay. So if a patient has diabetes, you need to counsel them. Okay. So outcomes of treatment, adverse outcomes, nerve damage, skin loss, and can it come back even after a release? Yes. So if you tell the patient that you're going to go to orthopedics and they'll get rid of it, I will find you. Okay, because they can come back. Make sense? Fingertip infections. Right. So this is not the other stuff we talked about before, right? Dog bites and cat bites. That's a separate category. Okay. So fingertip infections, right? So you guys already know about herpetic Whitlow, correct? That's those vesicles, correct? So Fallon and Whitlow go with pulp, puncture of the pulp. Everybody knows what pulp is, right? Right? Volar palmar aspect. Okay. Is that distal phalanx? Yes. It's also P3, right? We talked about this. Okay. The P stands for phalanx. Okay. And then paronychia or paronychia, depending on your pronunciation. That's a soft tissue around the nail. Okay. So a lot of times the predisposing factors for that is manicures, pedicures, right? You get on your toes. Ingrown toenails and hangnails. What's the most common bug?
Staph.
What's the most common bug for, that's a trick question. So what's the most common bacterial pathogen? It's staph. I agree. What's the most common for herpetic Whitlow?
Herpes.
Herpes. Wow. And it comes from human saliva. So dental hygienists and respiratory therapists, I guess, because the respiratory therapists are sticking their fingers into people's mouths, right? Especially when they're unconscious. Okay. So puncture wounds may be visible in a felon. pulp is swollen and tense, is that a very small area, the pulp, that can get, once it gets to a certain point, it feels like pus under pressure?
Yeah.
Yes. Okay, so that's exactly what your concern is. Okay? And then severe pain with tenderness, redness, and fluctuance. Everybody knows what fluctuance, right? It looks angry. It looks like it wants to squirt at you, if you will. All right? If you were to stick a needle into it, all of a sudden it's going to pop. Okay? So that's that tense nature, excuse me. So that is the pulp though, correct? So that's this one here. And here, okay? And then if we talk about paronychia, that's swelling on the one side of the base of the nail. Okay, paronychia here. It can be toenails too, correct?
Yes.
And less intense pain than a felt. Fusion of pain with paronychia is just that very discrete area. Once you lance it or make an incision, it drains like it's doing in that picture. Looks juicy, right? So then the pain actually goes away. So Whitlow, all right, herpetic Whitlow, clear vesicles on the erythematous base. Pants is coming sooner than you think, right? So what is the term? Clear vesicles on the erythematous base, okay? So, but the swelling should not extend proximal to what the flexion crease. So everyone understands that your DIP, if you look at the palmar aspect of your DIP, and you flex just at the DIP, you see that crease that it forms there? So it should be at or distal to that crease, but not proximal to it. So if it's proximal to it, do you think maybe it's in the flexor tendon and progressing and working its way down into the palm? Yes. Okay, that's what that means. Okay? Good to go? Radiographs, usually normal. They can show soft tissue swelling. But if there's a concern for osteomyelitis, especially if it's more chronic, then you can see those changes, that osteopenia that we talked about, correct?
Yes.
Okay. Partial or incomplete resorption of the distal tuft of the phalanx. So what that means is that's what you'll see. So as the infectious process sets in and takes over, then it starts eating bone. That's what you're looking at. Tuft, has anybody heard that term, tuft? Tuft fracture? Okay, that refers to the distal phalanx. All right, so more specifically to the distal portion of the distal phalanx. Okay, so a lot of times tuft fractures, if someone catches their finger in a door jamb, okay, then and the report says concern for tuft fracture, that means the tip of the tip. All right, so the distal aspect of P3 or the distal phalanx. Good to go?
Good.
Okay, so you may get an x-ray and you look at it, infection's been present, and then all of a sudden that definition of the distal tip is gone. It's been eaten away. Okay? Labs, cultures always, right? So CBC, CRP, and ESR. I want to leave that to that. So septic tenosynovitis we'll talk about at a later date. Okay? But that's that flexor tenosynovitis. Okay? So with the felon, right, so that's that pulp, right, so that's that space there. You're going to numb them up, right, so you're going to do a digital block plus drainage to include the puncture itself. Okay, you have to, if there's a poke hole away from where you put your incision, you're still going to try to at least explore that poke hole, make sure there's nothing in there. That's what they're getting at, okay? You want to clean it, right, so copious irrigation and debridement, right, and do not suture it closed. You just took a wound that was closed, made it open, took out the bad contents, and now you're going to close it back up? Do you think that purulent material, right? I won't say it. Purulent material might build back up if you close it back up and make another pocket? Yes. Okay. Oops. Paronychia, warm, moist soaks. Okay, so Epsom salt soaks for feet especially. Okay, 10 minutes, 4 times a day, and then if it's concerning enough, oral antibiotics. Okay, what do you think the most common organism is? Just out of curiosity, it's not on your slide. Staph, right? Or beta hemolytic streptococcus. Okay. So you're going to cover it with it. What was the antibiotic you guys learned last semester? Cephalaxin, correct? We use that very commonly, unless there's a concern for MRSA. Moving on. Severe, partial, or total nail removal. Okay? So especially if it's deep-seated enough, and you really gotta get in there, sometimes you gotta remove the nail to get up in there. So that's what they're talking about there, okay? If we take it to the operating room, a lot of times we move it in. All right, because we gotta be able to get in there, into those deeper spaces and pick out what's going on. You guys see that picture on the bottom left of the felon? Okay, so you see how the incision is lateral? Okay? All right, so you're gonna poke holes with the scalpel, right? And do you think I tell people it's like you need to be generous with that incision and with your exploration? Yes. You want to get in and break up any pockets of pus. Okay? Perinekia is pretty straightforward, right? You're going to nick those margins, like it shows you on the bottom right there, and take away any non-viable tissue. And then if something juicy comes out, you might want to do a wound swab. Do you think it's going to be polymicrobial? I guarantee it. Okay? Outcomes of treatment: painful scars, nail deformities, very common, recurrent infection with inadequate drainage. Okay, so if you don't do it right the first time, you're going to have to come back and do it again the second time. Okay, but it may be more profound if it recurs. Make sense? Okay. So, referral decisions. So, persistent or progressive swelling, I think makes sense. But when you talk about evidence of hand or limb infection despite drainage and antibiotics, that means you did everything correctly. You went in there, you opened it up, you let it drain, you left it open and drain, right? You did the right antibiotics, but it still doesn't improve. You need to call somebody, okay? Because maybe it's not what you think. Make sense? Okay? Or it may be more extensive, especially if they have any signs of systemic disease. Okay? I don't want to stop there. You guys good with that? Okay. Thank you for your attention. I'll see you guys tomorrow for lab.